Welcome to the C Podcast, taking you inside summaries of emerging evidence, the popular educational program from the American Society of Anesthesiologists.
Hello, and welcome to Volume 37B of the C program. My name is Natalie Holt, and I'm one of the members of the editorial board for Summaries of Emerging Evidence, an ASA educational program also known by the acronym C. For those of you who aren't familiar with the program, C is a continuing medical education program brought to you by the American Society of Anesthesiologists. The purpose of C is to keep readers informed about emerging knowledge in the scientific literature and how it might impact the practice of anesthesiology. The C editorial board reviews articles from over 30 journals each month to find clinically pertinent emerging content. We carefully craft a question and discussion reflective of the article content with the goal of highlighting new information in our specialty. Each volume contains 100 unique question discussion sets. Today, I'd like to give you a preview of a few of the articles covered in this latest edition of C. The COVID pandemic has had a major effect on health and healthcare worldwide. The long-term sequelae of COVID-19 illness have yet to be fully established. As such, the optimal timing of surgery in the context of a COVID diagnosis is also yet unknown. The authors of a recent international trial sought to evaluate morbidity and mortality in patients having surgery within 7 days before or 30 days after a COVID-19 diagnosis. The overall mortality rate for these patients was an impressive 23.8%. Of those who died, over 80% experienced a pulmonary complication. In an adjusted analysis, the only risk factor for pulmonary complications was ASA physical status of 3 or higher. Timing of COVID-19 diagnosis, preoperative versus postoperative, was not associated with a difference in mortality rate. The mortality and pulmonary complications in these COVID-19 patients were markedly higher than those reported in pre-pandemic studies. At this point, it's unclear whether these effects relate to long-term COVID-19 illness or other unknown factors. Recent guidance from the American Society of Anesthesiologists and Anesthesia Patient Safety Foundation recommends that elective surgery be postponed for a minimum of 4 weeks and up to 12 weeks after COVID-19 illness recovery, depending on symptom severity and the need for hospitalization. Opioid abuse and overdose have risen dramatically over the past several decades. In a recent study, data from the largest pediatric inpatient database in the United States were used to explore the demographics and comorbidities among children and adolescents admitted to the hospital for prescription opioid and illicit opioid overdose. The authors found that the vast majority of overdose admissions were from prescription opioids. Compared with illicit opioid overdose, patients with prescription opioid overdose were more often female. Mixed drug abuse was present in about 10% of each group. Concomitant benzodiazepine or antidepressant poisoning were more common in the prescription opioid overdose group, while central nervous system stimulant poisoning was more common in the illicit opioid group. Perhaps the most important point of this study is that it underscores the significant contribution of prescription opioids in the opioid epidemic in this country. Largely in recognition of the dangers of opioids, in recent years, there has been significant interest in identifying adjuncts to pain management that would reduce reliance on opioids for postoperative pain control. A recent prospective double-blind randomized trial found that intraoperative infusions of a combination of lidocaine and magnesium resulted in lower 24-hour morphine use compared to lidocaine-only, magnesium-only, or remifentanil-only infusions. Although no adverse events related to toxicity were observed, patients in the lidocaine plus magnesium group had a greater risk of experiencing hypotension requiring vasopressor therapy. Whether these differences in short-term opioid consumption have any meaningful clinical outcomes in terms of postoperative pain control and the development of chronic postoperative pain remains to be established. Coughing during emergence from general anesthesia is an undesired and potentially serious complication. During practice, most of us have developed our own favorite method to prevent coughing. Many medications have been used, including lidocaine, dexmedetomidine, and short-acting narcotics such as fentanyl or remifentanil. A recent meta-analysis found that compared to placebo, all these interventions had a greater likelihood of decreasing moderate to severe emergence coughing. However, interestingly, dexmedetomidine had the most significant effect, followed by remifentanil and fentanyl, while lidocaine administration was ranked lowest. Of the various applications of lidocaine, transtracheal administration was most effective, followed by intracuff lidocaine, then intravenous lidocaine. Total knee arthroplasty is one of the most common orthopedic surgeries performed in the United States. Many anesthesia modalities have been used for total knee arthroplasty in an effort to optimize postoperative analgesia and increase the speed of recovery. The adductor canal block has emerged as a tool to improve postoperative pain relief following knee arthroplasty, but it is well known that it does not provide complete coverage of the posterior knee. The authors of a recent small randomized trial sought to evaluate the impact of adding another block to the adductor canal block. The so-called IPAC block is an injection of local anesthetic to the interspace between the popliteal artery and capsule of the posterior knee. Although patients in the IPAC group had lower average and worst pain scores at rest in the recovery room, there were no differences in opioid consumption or recovery room time between the IPAC group and the adductor canal block alone group. Based on this study alone, there is insufficient evidence to support the addition of the IPAC block for management of postoperative total knee arthroplasty pain. Another article in this volume of C discusses a common problem related to the use of continuous peripheral nerve blocks, which are frequently used in the management of anesthesia for orthopedic procedures. One of the challenges with continuous blocks is catheter migration and dislodgement. The traditional approach to catheter placement is a through-the-needle or over-the-needle approach. The authors of a recent trial evaluated the effectiveness of a novel suture-shaped needle with a following catheter. The trial, involving 70 patients, compared the suture needle with the through-the-needle catheter placement approach for ultrasound-guided popliteal sciatic nerve block. Based on the primary outcome of pain scores measured during the first 48 hours postoperatively, suture needle catheter placement offered non-inferior performance compared to a through-the-needle approach. However, at 3 days postoperatively, 9% of the through-the-needle catheters were found to be dislodged, compared with none of the suture needle-placed catheters. Suture needle-placed catheters also leaked less. One patient in the suture needle group experienced a deep venous thrombosis and pulmonary embolus, but recovered. Whether the larger needle and greater tissue trauma from the suture needle contributed to this complication is unknown. This study emphasizes that research on improvements in anesthetic techniques and equipment is an important component of the development of this field. Lactate is a well-known marker of tissue hypoxia, and lactate levels are commonly used in intensive care units to guide the treatment of sepsis and other disease states. Early onset hyperlactatemia in the intensive care unit after cardiac surgery has been associated with poor outcomes. The authors of a recent study sought to evaluate the prognostic significance of trends in intraoperative lactate levels during cardiac surgery with cardiopulmonary bypass. They found that a more than threefold increase in intraoperative lactate levels was associated with increased 30-day mortality risk and need for renal replacement therapy, as well as longer intensive care unit length of stay. These findings may be useful when making decisions regarding fast-tracking or identifying patients at high risk of postoperative complications. Dehydration occurs in various clinical scenarios, including the postoperative period. Plasma osmolality is a common marker for dehydration, and thirst is generally considered a reliable indicator of plasma osmolality. The authors of a recent study sought to evaluate whether individuals with access to self-administered intravenous fluids would be able to adequately rehydrate themselves according to thirst levels. Dehydration was induced with vigorous exercise in hot conditions. The study found that healthy individuals no longer requested fluid boluses once their plasma osmolality reached normal levels, suggesting that thirst can reliably guide fluid replacement. Whether these findings could be duplicated in patients with pathological causes of dehydration or pre-existing disease, and how this finding might influence clinical care remains to be established. The perioperative period is widely regarded as an anxiety-provoking time, and one of the jobs of the anesthesia provider is to alleviate this anxiety. In order to do this, anesthesia providers must earn the respect of the patients they are treating. In the United States, 0.7% of adolescents identify as transgender, and this is probably an underestimate of the number of transgender youth in this country. Transgender youth are at increased risk for mistreatment in healthcare, resulting in long-term negative consequences. In this volume of C, we include an article that discusses the terminology around gender identity and how best to relieve anxiety and improve the quality of care offered to individuals undergoing gender-affirming hormone therapy or surgery. Most of us have been called to perform anesthesia for an emergency appendectomy. In fact, emergency surgery has been the mainstay of appendicitis treatment for the past several decades. However, the results of a recent multi-center randomized trial have called this approach into question. A total of 1,552 participants were enrolled and randomized to either surgery or aggressive antibiotic treatment for the management of uncomplicated appendicitis. They found that for the primary outcome of 30-day health status, antibiotic treatment was non-inferior to surgical treatment for acute appendicitis. Whether these results will change clinical practice and save us a few phone calls in the middle of the night remains to be established. I hope you've enjoyed these highlights from Volume 37B of the C program. If you don't already subscribe to C, you can do so by going to the ASA website, asahq.org, then navigating to Shop ASA and filtering for C in the category drop-down. Thank you, and on behalf of the C Editorial Board, we hope you enjoy this edition of Summaries of Emerging Evidence.
Thank you for listening to the C Podcast, presented by the American Society of Anesthesiologists. For more information on summaries of emerging evidence and other educational products, please visit shopasa.org.